Good afternoon. Let's start our session. My name is Marcelo Amato. Andres Esteban is the co-chairman of this session. And we are going to talk about mechanical ventilation. And the first speaker is Art Slutsky, who is going to talk about constant flow ventilation.
Thanks very much, Marcelo. It's a pleasure for me to speak on this topic, which has sort of been an interest of mine for a while. There'll be some clinically relevant information, but some of this will just be physiological information on what constant flows mean and how they can actually help us learn about physiology. So what do I mean by constant flow ventilation? Well, if you look at conventional ventilation, shown in the schematic here, this is respiratory rate on the x-axis, tidal volume on the y-axis. Conventional ventilation fits in here. The respiratory rates are between 8 and about 30, 40, 50, 60. The tidal volumes are clearly greater than the dead space. We have techniques of high-frequency ventilation, and there's techniques of constant flow ventilation that essentially have no respiratory rate, no tidal volume. It's a matter of putting gas in at a constant flow. And that's going to be my topic today. There's a few different techniques: apneic oxygenation, tracheal insufflation of oxygen, constant flow ventilation, and I'll describe each of these in a little detail as I go through. Now, the concept of using constant flow ventilation is actually not a new one. Robert Hooke in 1667 presented to the Royal Society of Medicine. He was the curator of the Royal Society of Medicine, and his job was every week to present to the members of the Royal Society some interesting experiments. So in this particular experiment, what he did was he took a dog, shown here. He put holes in the chest wall and had tubes coming out of the holes. And then, as you can see, he had a bellows at the airway opening and blew gas into the lung of the dog at a constant flow rate. And what he found was, remember, this was 1667. This was before we knew what oxygen was and CO2 was. So when this being continued for a pretty while, that is insufflating the dog with a constant flow, the dog lay still as before, his eyes being all the time very quick and the heart beating very regularly. Upon ceasing this blast and suffering the lungs to fall and lie still, the dog would immediately fall into dying convulsive fits, but he soon revived again by renewing the fullness of the lung. So what Hooke did was to show that ventilation was important for maintaining the dog alive. Again, remember, that was before they knew about oxygen. The reason he did this experiment, because it was thought at the time that breathing was important for the circulation. That is, that you had to have rhythmic breathing to help the heart pump blood. Clearly disproven with this constant flow. Now, the techniques of constant flow that have been studied over the last little while are somewhat different than that. There are techniques where constant flows are used in apneic patients, apneic oxygenation, tracheal insufflation of oxygen, and constant flow ventilation, and I'll talk about these a little bit, given the short time I have. And then there are techniques where constant flows are used essentially to decrease the dead space, to try and either decrease the work of breathing in spontaneously breathing patients, or decrease the dead space and therefore allow lower tidal volumes in patients who are being mechanically ventilated. That is called tracheal gas insufflation. I'm actually going to leave out this tracheal gas insufflation because that's been covered a number of times in this meeting, and I thought I might show you something a little bit different in this particular talk. So the concept of apneic oxygenation. In fact, this technique was first described in the 1940s by Draper and Whitehead, and the term they used was diffusion respiration. And as I'll show you in the next slide or two, the concept really was, the mechanism was not diffusion that led to the oxygen improvement in oxygenation, and there wasn't respiration because there was no CO2 removal. And the basic concept, the basic way to apply this is to take a source of oxygen, ventilate the patient or have them breathe spontaneously with 100% oxygen for some period of time to basically denitrogenate the lungs and blood, then put that source of oxygen at the airway opening, and then the patient could be paralyzed or the animal could be paralyzed. Remarkably, if you do that, it's possible to maintain oxygenation over tens of minutes and, in fact, an hour. And I'll show you some data actually published I'll show you the mechanism first, then I'll show you some specific data in humans. This is how this works. During apnea, most of the CO2 produced goes into the tissues. We have a huge buffering capacity for CO2 in tissues. And let's say that's about 90% of the CO2 production. The rest of the CO2 enters the lungs. That's about 10%. Oxygenation continues at the same rate it did before. The circulation is still going on. You're still using oxygen. Therefore, a lot more oxygen is leaving than CO2 entering. This creates a negative pressure in the alveolar region and actually sucks gas, which is oxygen in this case, because that's what was placed there, into the lungs. So one using this is able to maintain PO2 very high, but CO2 rises. So let me show you some data in humans. I can show you some animal data, but I'm not going to. This is taken from a paper published in 1961 by Fruman and colleagues in anesthesiology. They took patients who were going to the operating room for routine procedures and applied this technique of apneic oxygenation. Now, this was before there were ethics committees, because as you can see, what happened with these patients over anywhere from 45 minutes to an hour, here are the blood gases. This oxygen saturation in all patients was greater than 98%. But the PCO2 was slightly elevated, from anywhere from 125 to 250 in one patient. And the pH in that time frame, in one patient reached a level of almost 6.7, between 6.7 and 7. This was really quite remarkable if you think of it, and this actually is the rationale behind permissive hypercapnia. Acute CO2, acute increase in CO2, respiratory acidosis, is very well tolerated in patients who don't have other diseases. And in fact, I didn't tell you this, but in these patients, none of them had major problems. There were minor arrhythmias, a couple minor arrhythmias, and the patients apparently did well, although they weren't followed long-term for neurological function. But pretty dramatic results with just apneic oxygenation, absolutely no breathing. These patients were paralyzed. And we use a technique like this for looking at brain death in the ICU. The next technique is something called tracheal insufflation of oxygen. And the concept here was, you know, if we have mass casualties in a war zone or in a terrorist attack, how are you going to ventilate all these patients? You can't have ventilators for everybody. So we hypothesized that if you just put a catheter into the trachea and flow oxygen at a relatively low rate, 2, 3, 4 liters a minute, one might be able to maintain oxygenation for a prolonged period of time and keep the patients alive until you can do something more definitive. And so the data I'll show you were in paralyzed dogs. This was published almost 20 years ago. Constant flow at 2 liters a minute, and then we measure blood gases. Very simple experiment. And here are the results. This is time on the x-axis, PO2 or PCO2 on the y-axis. This here represents the change in PCO2 when we had these animals do apneic oxygenation. So without a catheter in here, just complete apneic oxygenation as I described it earlier. And here are the blood gases with this constant oxygen insufflation or tracheal insufflation. You can see that PO2 rose quickly to about 400 and stayed about 450 for many hours, 4 or 5 hours. PCO2 increased and stabilized at about 125 to 150 in this animal. And in all animals, we were able to do this. Get normal, very high PO2s, high PCO2s, but the animals tolerated this extremely well. So this is a technique that theoretically could be used in mass casualties. What about using, I mentioned airway insufflation during spontaneous ventilation. And the rationale here, as I said, was really to decrease the dead space, therefore decrease the work of breathing. And this could potentially be used in patients with impending, I put respiratory failure, but really ventilatory failure. This would work best in patients who have relatively normal lungs, but have a problem with ventilation. So this was a study published about 15 years ago in dogs. We used a ventilatory failure model. Basically, we gave repeated low doses of a paralytic agent to produce respiratory muscle weakness, but not complete paralysis. This produced a steady state PCO2 in these animals of 90 plus or minus 15. Pretty severe respiratory acidosis due to muscle weakness. And then what we looked at was varying the catheter position and the flow rate. We put a catheter either proximally or elsewhere. And I'm just going to show you data where we put a catheter proximally blew gas in at a few liters a minute. Here is the change in PCO2 and the change in minute ventilation that occurred in these animals. Remember, these animals are given a low dose of paralytic agent, so they have muscle weakness. Then we're just reducing the dead space with this constant flow. And here's, if you look at the proximal values, that is a catheter just a little bit north of the carina, the tracheal carina. You can see the PCO2 decreased by about 20 millimeters of mercury. So it started about 90, went down to about 70, and some animals went down to the normal range. You might think, well, that's very nice, but what if it mean, how do we know the work of breathing actually decreased? Well, look at the minute ventilation. In fact, the minute ventilation dropped by 40% in these animals. So at the same time their PCO2 dropped, their minute ventilation dropped. So again, this potentially could be a technique in patients with impending or with ventilatory failure to just tide them over without having to intubate them. Now, the final technique I'll talk about is a technique called constant flow ventilation, and I think I still have time. And this is a technique in which we looked at, could we get relatively normal blood gases in animals with a technique in which animals are paralyzed, but we blow gas in at a constant flow rate. That hadn't been done before. The data I showed you and the data in the literature previously had been on animals in which PCO2 was allowed to rise, or not allowed to rise. The techniques didn't provide sufficient gas exchange to lower PCO2 to normal. So we used a very simple experimental setup. A couple catheters into the main stem carina, each main stem carina, and blew gas here, pretty high flow rate, at a constant flow. Animals were completely paralyzed. And here are some of the results. This is just a plot of flow rate and PCO2. And you can see that, as expected, the higher the flow rate, the lower the PCO2. And you can see that in all animals, we're able to get normocapnia, or indeed hypocapnia, using this technique with flow rates on the order of 0.4 to 0.8 liters a second. Pretty high flow rates, in fact. So this showed that there's a technique here that we could use. And this technique, we actually, the first thing we did was to see whether we could use this in a ventilator-induced lung injury model. Because we think about the mechanism of lung injury, if you think of over-distension and de-recruitment, this technique could be the perfect technique where you raise mean airway pressure, you have a constant flow rate into the lung, you have no excursions in tidal volume, essentially. That should be the minimum way of injuring the lungs. Fortunately, this technique worked extremely well in dogs. Didn't work so well in pigs who don't have collateral ventilation, and I guess humans. It didn't work that well in humans that are somewhere between dogs and pigs, and I won't say closer to which of those species. But this technique is an interesting one we found for looking at physiology. And let me just show you one example of some physiology that we could do with this preparation. So this is an animal that we published this about 10 years ago in Journal of Clinical Investigation, looking at respiratory sinus arrhythmia. Here you have oxygen saturation, about 95%, heart rate between 90 and about, this is 100 to 150. This is the phrenic neurogram, and this is the esophageal pressure swings. And you can see, as you'd expect, with each esophageal pressure swing, the phrenic neurogram goes off, of course. And associated with each of these, there's an increase in heart rate, right? That's respiratory sinus arrhythmia. And if you ask most people in the audience, well, what's the mechanism of this respiratory sinus arrhythmia? Many people would suggest, well, what happens is you breathe in, you lower interpleural pressure, that afterloads the left ventricle, blood pressure drops a little bit, therefore heart rate increases. Makes a lot of sense. Well, let's look at this preparation now. This is just spontaneous breathing on the left here. As you can see, there's changes in esophageal pressure. What we did was we did constant flow ventilation to maintain the same PCO2 and the same saturation, and here's what we found. This is now the same saturation up here, you can see. You can see here you get respiratory sinus arrhythmia, but notice that it's much larger, the rate is slower. The phrenic neurogram is still firing, but the animals are paralyzed. So you don't get any change in esophageal pressure. And yet, despite the fact that there's no change in esophageal pressure, you still get respiratory sinus arrhythmia. So this preparation, I think, is a very interesting model for which to study heart, lung, brain interactions, get rid of the oscillations in pressure due to mechanical ventilation or spontaneous breathing, and see intrinsic properties of heart-lung interactions. This was also useful for us. We looked at the effect of hypoxia on the heart rate response. And as we know, with spontaneous breathing, you get a tachycardia usually with hypoxia. Turns out with constant flow ventilation, you get a bradycardia with hypoxia. That there's some interaction between brainstem and heart that causes the tachycardia. And you can think of that as the diving reflex in the seal. This kind of preparation allows us to address that. So in conclusion then, there are multiple techniques associated with constant flows, and I've described some of them. The clinical utility varies a lot with the technique. Apneic oxygenation, we've all have used in our ICUs in some form or another to look at brain death. And in fact, although it's called apneic oxygenation, usually it's used with a catheter, which really, in fact, isn't apneic oxygenation per se. Tracheal insufflation of oxygen that I showed you may be useful in terms of mass casualties, at least for temporizing and keeping patients alive for a short period of time, or short period meaning many hours until more definitive ventilation can occur. And then constant flow ventilation, which I'd hoped it would be a useful technique in patients, but probably not, but I think is a useful physiologic tool, as I showed you, and there's other data that have used this technique. I think the future utility of some of these techniques is still being investigated and still being used in some ICUs for various things. So that's the conclusion of my talk. I'd be happy to answer any questions. Thank you.